First of all, thank the organizing committee for having me here and to express my gratitude towards Professor Philippatos and especially Professor Karamasis. And without further ado, let's dive into our case regarding left main bifurcation PCI. So hereby we present the case of a 62-year-old male gentleman with low effort angina, and regarding cardiovascular risk factors, he had been suffering from dyslipidemia with a positive familial history of coronary artery disease and a known prior coronary artery disease with a disc implanted in proximal LAD 5 years ago. He had done an inconclusive treadmill testing and was further referred for a myocardial perfusion imaging, which was positive, indicating reversible ischemia in the anterior apical wall. So what to do? We had an invasive angiogram done. As you can see in the caudal views, maybe things look quite good, except for a haziness in the ostial LAD part, maybe, some could argue. Some more caudal views with a guiding catheter. But the picture was different in the cranial views, as you can appreciate. We weren't quite sure whether we were dealing with a really ostial LAD disease or maybe a distal left main disease, as you can see for yourselves. So based on the acquisitions and the images, how would you treat this patient? To say our point of view, we really thought...
This question to the panel?
Okay.
I think the first question is whether we know exactly the lesion. So who from the panels wants to talk exactly the location and whether they need more information? Pavlo, do you want to start this or?
Yeah. I'm Pavlos Bounas, a cardiologist interventional from Triasio General Hospital. Nice case. For this, I would probably use IVUS here. There seems to be a lesion in the proximal, in the ostial LAD, probably in the left main also, and towards the circumflex. So we need anatomy here, besides physiology, so imaging is necessary for me, I believe.
Yes?
Yes, Pappas from Atticon Hospital. Definitely there is a lesion of the ostial LAD coming back possibly towards the left main. I don't know, there is a stent on the proximal LAD, possibly there was a plaque not treated in the previous angioplasty.
Previous angiography wasn't that bad. He had a spot lesion in proximal LAD. With a 3.5.
Probably it was done without imaging, so you can definitely say what was going on. We need to see the previous angioplasty. Definitely, we need to do an imaging to see the distribution of the plaque on the proximal LAD at the distal left main.
So this is clearly, I mean, there's a bifurcation lesion, at least you know the way angiographically looks like. The IVUS, I think, will confirm that, probably. The question is, how would you treat that? I mean, the IVUS will give information about whether the circumflex has significant disease or not, whether it's going to be a provisional standing or you will have to... So that's more the discussion. What, Dr. Tsiafoutis, what do you think? How would you...
I'm Dr. Tsiafoutis from Red Cross and hospital. I think I would like to see the anatomy, and then I'll decide how I will treat it, because it depends on the angulation, how is the circ, and there's a proximal, another diagonal proximal. So let's see the anatomy, and then we'll decide, I think.
Okay.
Shall I add a few words? Number one, fantastic case to show how much is the variability of the angiographic view. It was showing 3 views, perfect, no problems. And then you needed to search. And you can imagine how much you can differentiate what are you doing based upon how much time you are spending in searching exactly what could be the problem. The second one is which type of technology, because everybody said imaging, I'm going to use IVUS or OCT if IVUS, high quality IVUS, because the bifurcation is going to be very important. The question are, do we need to have just one pullback from the LAD into the left main? Also to know the plaque, the sizing for the pot, from where to land. We needed to cover the entire left main. That seems to be very long. Or we can just land in before and not avoiding the ostium. So there are so many aspects. The alternative is doing in two vessels, a little bit more challenging, but possible.
Thank you. I think we all agree that IVUS, as suggested by your opinions and by recent guidelines, is mandatory. So that's what we did. You can have a look for yourselves during the IVUS run in order to really assess the severity of CAD. And at the right part, you can see the assessments made regarding MLA of both ostial LAD and distal left main, point of confluence, which really show very nicely that we had to deal with the distal left main ostial LAD disease with both MLAs being severely obstructed. As you see, 4.29 regarding ostial LAD and 4.92 regarding distal left main. And the wire to circumflex really helps us clear the path for the measurements. And this is a way to go when regarding left main bifurcation IVUS is used. So we also noted that both lesions, or one lesion, as we could say, and suggested by the experts, have been heavily calcified. You can appreciate for yourselves that ostial LAD seems to have a 360 arc of calcium, and the arc of calcium regarding distal left main is also almost 300 degrees, we would say. So that changes things, and this is valuable information that we took from IVUS. What to do next? We postponed the case and brought it back to the cath lab. And after that, we had already decided that we would go after.
Can I for a second
yes.
interrupt, because these are important. First of all, you have to answer whether you have disease up to the ostium of the left main, so to know where exactly your stent should land, whether it should go up all the way up or not. Because it's a long, like Professor Guagliumi mentioned. I mean, you have to know that.
Maybe
the second is, if you can go more slowly, ostial circumflex does not seem to have significant disease, if I'm correct. That's what I saw. If you can go a little more slowly.
Yes.
On the pullback.
So let's activate the pullback again, okay? So very important also to have a look at the measurements. The mismatch between the proximal LAD and the left main. The left main is huge. In yellow, you have the lumen. In blue, you have the
so you have some calcium there, you see,
calcium
and then
there.
comes the circ.
Circ is coming on the top.
It's not bad on the top, yes.
There is a little bit of calcification, but by definition, not bad. Yeah. And you can see that the ostium of the circ is going to be, by measurements, at 492.
And the left main at the proximal is okay, I think. I didn't see any.
Correct.
Any
proximal mid seems to be okay. So let's try to see the panel, what they are thinking about. So we got this interpretation, imaging interpretation. How do you want now to proceed based upon the imaging? So what we call actionable imaging.
I am Dr. Gavrielatos from Janio. I think now that we have a knowledge about the calcium, because without the IVUS, we do not know if it is eccentric, if it is concentric. As it was mentioned previously, it is concentric at the point that it is the most large stenosis, and also we know that there is no much calcium at the ostium of the LCX. So I think that now we can proceed with a provisional standing, and after that, to see how it is going to be the ostium of the LCX, first with a balloon. I think that after balloon also we need to do some IVUS after any modification technique in order to see what happened after that and see about the carina and if there is any shift of the carina. And after that, proceed with stenting according to the measurements, having in mind that we have to use the distal landing zone as a point for the stent sizing.
Okay, Dejan, one question about the stent size. So you said perhaps we are going to proceed with a provisional stent. So you have the measurements, and there is still a significant difference between a distal and proximal. How to size the stent for this left main LED prox?
Yeah, so the classical recommendation is to size the stent according to the proximal LAD in this case, which is the distal main vessel in the characterization of the bifurcation, which is let's say up to 3.5. I would tend to take a 3.5 stent, even though it's the upper limit of the diameter, just because I know I will have to overexpand it in the left main to what seem to be 4.5. So to do that, you first need to know about the overexpansion capacities of different stent platforms. Rarely you will see a 3.0 stent which can be safely overexpanded to 4.5 on the bench. So you will be more sure if you don't know exactly, if you don't have the table in the cath lab. This anatomy you will be more secure if you take a 3.5, because most, if not all, 3.5 stents platforms will go to 4.5 without damaging it on the bench. That's the first information. The second information regarding sizing is the length. Now, there was a talk also, and I think this is important. Intracoronary imaging will tell you whether you have diffuse disease up to the ostium, so that you can decide based on that whether the stent needs to go to the ostial left main. However, if you do, I tend to very often go to ostial left main. I'll tell you why. If you do not go to the ostial left main, even in the absence of disease like this here is the case, because we don't really have a large disease here on the pullback, there are two risks. The first is, if the left main is too short, you will not find a short enough pot balloon to accommodate for the difference in diameters. So if there is a short left main, by default, I go to the ostial left main without any disease also.
But here we have a long left main.
Exactly.
Let's
so
go back.
I'm going to say the second point. So the second point, if you have a long left main, why I would tend to go to the ostium, not always, but often, is the following: the pitfalls of pot. So there are several pitfalls of proximal optimization, one of it being that we try not to go out of the stent with a very large balloon, like 4.5 and 5.0, not to damage the intima outside of the stented segment. This bears the risk of missing the proximal stent cells. So I've seen many cases where the stent is finished in the middle of the long left main, and the operator performs pot, but does not expand the first few cells. Now, you will have a gross malapposition, 3.5 stent in the 5.0 left main or a 4.5 left main. For like 1 millimeter or 2 millimeters, you will have a gross malapposition. This will likely not affect the outcomes if you don't do anything else. However, if you want to cross to the circumflex, now or in any future procedure, there is a huge likelihood that you go underneath that 1 millimeter and destroy the stent with the future interventions. So this is why I am always very careful when I do it. If you have IVUS on the table, you can check for all this at the end of the procedure and correct.
Okay, a little bit of disagreement in this case because I think you might have different tools to be very precise and to avoid to get malposition. The first is measurements. Now we know exactly how big is the vessel, and when we are taking the balloon for the pot, we know exactly that the balloon should reach at least 4.5. That is the point. And then you can use clear view, any type of technology enhancement to be sure that you are not leaving a large malposition. And imaging at the end, that is the most important, is going to tell you, especially if you're using OCT with a very precise way, if your stent is against the wall or not.
I agree. So imaging helps you at the end avoid this pitfall.
Okay.
I mean, take your point seriously. I would agree, although comments were excellent made, but I think if you combine imaging, if you have the stent boost, you have all your data, you can repeat, you should be able, as an experienced interventional, to not to miss the proximal struts and have a good result. We know that the longer the stent, the probability of getting, although it doesn't happen so often in the left main, but restenosis, problems with the aortic. So it's if you are, you have all your tools, I think you can do a great job, provided what you have on your data.
Super. We saw that you was in trouble with the calcification. Going back and show what was going on, and then we are
Okay, thank you. Excellent opinion so far. So, as predicted by Ivus, we really had to deal with a lot of calcium regarding ostial LAD and distal left main. And this is the use of a NC 3.0 by 12 NC non-compliant balloon, which seems to have a dog bone effect, as you can see. And that was predicted because it had a calcium ring of 360 degrees angle arc. So afterwards, we had to really change the strategy regarding fighting calcium. So namely, in this case, we used the help of shockwave. And after 6 runs of using a 3.0 by 12 shockwave balloon, we had an adequate expansion. And we kept on predilating with an NC of 3.5 by 12 millimeter balloon. And then we were satisfied as far as predilatation before implantation of the stent. You can see some resolution of the dog bone effect.
Let's stop for a second.
Okay.
Are you satisfied about what you are seeing in angio? That was obtained after a non-compliant balloon following the shockwave?
Yeah, this is the shockwave, the 2 of the 6 runs of the shockwave.
And then at the end of the shockwave, you are doing again
an NC higher, balloon? Yeah.
Okay, and it was a 3.5?
A 3.5 by 12 at 16 to 18 atmospheres.
And this is on the right panel, or?
It's both regarding the shockwave, these two panels.
This is the balloon of the shockwave or not?
Yes, this is the shockwave balloon.
It's not a high compliant balloon, non-compliant balloon.
So very important to judge the final results by using a non-compliant balloon. Do you want to?
Yeah, I think it's an interesting question what you ask. So when you ask, is it enough? The question is whether we can judge by angio at all. So one school of thought, and the one that I practically use, is to inflate a NC balloon sized exactly to the diameter that I will pick the stent with, from at least 2 projections, and if it's expanded, usually it means it's okay. However, if there was a nodule, it can come back. So I would tend to use imaging after plaque modification to see what I did in terms of plaque of modifying the calcium, whether I have fractures or not, whether I gain any lumen or not. So this is what I would tend to do before I go with the stent.
But let me ask you, if you have what the size was to the left, 3.5 we said, is that right? But if you put a 3.5 and you do your shocking wave, intervention, and you have a very good, excellent inflation of the balloon at 6 atmospheres, nothing, I would just go ahead and do an angio, make sure you don't have any big dissection downstairs, and then proceed. I wouldn't do a non-compliant. Why do it? After the shockwave. After the shockwave,
I would do NC for sure, to be honest. So I always follow up with the NC balloon after the shockwave because I want to go with the diameter of the stent. And even if the shockwave was at the diameter of the stent, I would like to remove. So what happens often is after the shockwave, even if you have fractures, you can have spikes protruding into the lumen. So the passage of the stent is not always easy after preparing the calcified lesions. So with the NC balloon, I tried to make more lumen and to see whether it's expanded enough. This is why I follow it up with the
So
this is a preparation.
I totally agree as well.
Exactly, it's a preparation. Exactly.
I totally agree as well. After the shockwave, I do NC balloon to see if it's expanded in the two projections right and properly, and then we take an imaging, and then we try to put a stent.
Lesion preparation is very important because you have cracks on the calcium. That's why I brought the issue. It's not that you have prepared it well for the stent expansion. So you need that, okay, to be able to actually have a good result afterwards.
If you say in a two projection, you must use the two projections, huh? Because otherwise everybody is talking about the two projection, and then in the vast majority of the cases you saw just one single shot in one single projection. So especially here, we saw that there was some eccentric calcification at the ostium, and then it was becoming very concentric. So it's very, very relevant to get the appropriate judgment. And perhaps also the enhancement technology in the future might help more and more in getting the calcification spot after the lesion preparation.
Let's go ahead.
Okay, let's follow with the case. Excellent comments. So this is a stent deployment, fairly enough deployed, but I see that your point you made that maybe there is an under expansion. And afterwards, we finished with a pot. We used the pot balloon of NC 4.5 by 12 millimeters, and we inflated up to 16 atmospheres. So this is the pot on the right upper acquisition. This is the steps of the PCI, highlighting the case, and some images. We had to make the way because we chose the strategy to use overlap between the prior implanted stents 5 years ago and the new stent that we sized. And we used clear techniques, stent visualization techniques. This is a dog bone effect that we've already discussed, the use of the shockwave as plaque modification techniques, the desk selection, and the pot. Before we finish, as you all highlighted, we also do this in our cath lab, maybe not 3 times in a row when dealing with left main bifurcation, but at least 2, meaning pre and post PCI. We did an IVUS run to check for the result. I will let you give you some seconds to see the IVUS run and the measurements. We were happy to see that at least at almost every part, the stents of the new DES were nicely opposed to the wall with good expansion and no major mechanical issues like, say, a large dissection, etc. And all MSA measurements were within accepted values. So we were happy with the result. And afterwards, we always take it with angiography, but this is the imaging part.
So I think it's great. You finish with a 9.6 millimeter square on the proximal LAD, and there is no malposition at all. Mm-hmm. Please consider that it was using HD resolution. One point that I do not understand, when you are acquire this imaging, mm-hmm. you have also the longitudinal view. And nobody is using the longitudinal view. And if you are dealing with bifurcation, that is dramatically important. You can turn the axis and see clearly, also in IVUS, in the longitudinal view, the bifurcation. People are talking about carina. You can see the carina. So it's very important here, high resolution, precise measurements, how to use for planning and controlling the optimization, but use also the longitudinal view. That is very, very relevant.
It's a very good, excellent result. Any comments?
I think that very nice job and excellent result also. I think that it is needed to do some IVUS after the modification technique. Not only to confirm that there are the cracks and all the modification that is done had the result, but also for better sizing after the expansion of the vessel and after the calcium modification. Also, maybe you have some more information after the modification about the morphology of the plaque, or about any protrusion that Dr. Milasinovic mentioned, that you may need to do some further modification or not. We usually do it in our lab. Well, if you don't have time, okay, it was very well expanded, so you proceeded with the stent. And of course, it was very useful, and it is always useful to do the IVUS after the PCI to check the edges and to see if there is any under-expansion or malapposition.
Can we look at the last angio so we can
Yes,
conclude the case?
So these are the caudal views post-PCI.
Okay, good result. I mean, one question to the panel would be who would have done a kissing balloon just to have a very good entrance into the circumference in the future? Yeah. Would someone do that, or
just brief comments? I would do another run after the balloon to see the crackles, of course, and I would do a run in a circ after the procedure, after the balloon, the pod balloon, to see how is the osteum. That's a point.
But anyone would do a kissing to maintain entrance to the circumference?
Yeah, usually end with a kissing.
We did it?
I think that if pod is, if the result after pod is satisfactory, kissing is not mandatory. Okay, but usually this stands for non-left main bifurcation. Maybe in left main we should be more aggressive and do the kiss. But okay, if you have any plaque shift after that or any dissection, you should use a stent. But if pod is nice, has a nice result, I don't think that you have always to do the kiss.
Okay, Dr.
But you can see it better if you use the IVUS also in the LCX.
Okay, we will have Dr. Milasinovic to conclude the case.
And before I leave, this is the automated IVUS report we use in every case regarding IVUS-guided left main PCI on site. We do this quite quick check. It lasts about 30 seconds, and we know roughly what to deal with during left main PCI that we use IVUS in our cath lab. Thank you very much.